So what I'm going to do is tell you a bit why we wanted to have some of the UK Biobank specifically to address some of the questions which we can't address in some of the studies we do within our centre. So therefore, I'm going to give you a bit of background about arthritis. When we asked for some of the data, we actually had two sort of research questions. One was looking at the outcomes in arthritis, and the other one was looking at some of the risk factors. So who is developing arthritis? What are those factors? So just a bit about the background. Take the term rheumatological conditions. There are about over 100 different sorts of rheumatological conditions and they can sort of affect everybody. Even children can get arthritis up until the older age. Sometimes there is an inflammation component involved, and then we talk about arthritis. So examples are rheumatoid arthritis and psoriatic arthritis, and that's something we're especially interested in our centre. So we know if we just look in the general population, about 0.5% of 1% of the population will have either psoriatic arthritis or rheumatoid arthritis. And as mentioned, it is an autoimmune disease. So what does it actually mean, an autoimmune disease? So a bit of background. So normally our immune system fights against sort of external agents. So if there's a virus, your body responds to that. There's some cells and there's some activation, and we try to tamper down some of the inflammation from the external factors. But with autoimmune, that means that we actually fight against some substances or some tissues within our own body. So that the balance where we normally have good and bad cells within our body, that's sort of tipped towards the bad cells. So one of those sort of imbalances in our immune system might cause inflammation, which is one of the important factors in arthritis. So this is just a representation of one of the bones in our body. So up there is the bone above and below. Then there are some sort of tendons and muscles around your joint. So just make sure you're stable as well, and of course for the movement of your joint. Then there's part which is called the synovium and the synovial fluid. And that's where often these bad cells accumulate and cause some damage. So some of these cells, so there's a lot of inflammation in the synovium, so some of your joints may become quite stiff, they may become very swollen or tender as well. But also some of these cells may go into your cartilage or your bone, and that causes quite a lot of. So where is this damage in general? So actually it can be almost everywhere. But in rheumatoid arthritis and psoriatic arthritis, it often starts in your hands, so in the smaller joints or in some of your joints in the feet. But it can also involve your knee joints or your hip joints or sometimes your elbow or your shoulders. Although we talk about rheumatoid arthritis and psoriatic arthritis, they are different sort of diseases. Of course, in psoriatic arthritis, it includes the name psoriasis. So these people also have psoriasis, so there's some involvement of your skin. So this is an example and picture of somebody with sort of involvement of the skin of your one of the fingers. There's another sort of difference. When I said the cell can cause damage to your joints, here you see like little bites out of your bones. And of course you can imagine it's very painful, and some of these bones and your fingers become kind of stiff and deform as well. There's So what do we want to sort of know, and why do we want to look at these questions in the UK Biobank? So as mentioned in the introduction, it has a huge effect on patients' life because it's a chronic disease. There is some medication available, but there's no cure for arthritis yet. So we saw already that a lot of people may have damage in the joint. As a consequence, there are some difficulties when people do their daily task. So people have difficulties opening a bottle of milk, walking stairs, just walking outside. People also have problems at work. We know, for example, that about 40 to 50% of patients have to stop working within the first 5 years after the diagnosis. But it also may cause some other diseases, sometimes due to the disease itself, but sometimes also due to the medication these people use, because the medication is especially directed towards the immune system, and that then makes cause other problems as well. We also know that a lot of people with arthritis have other diseases, especially these people have a lot of problems with their heart, so cardiovascular diseases, sometimes lung diseases as well. So what we are especially interested in is how often does it occur, people with these comorbidities, and how does that affect how you sort of function in daily life as well. So some previous studies have already looked at it, so why do we want to look again at the UK Biobank? So I think one of the problems is that a lot of people doing these studies just look in patients with arthritis or just look in the general population. And you can't always compare these studies together. Often, I said in the beginning, there's many types of arthritis. Often people just look in rheumatoid arthritis or just look in psoriatic arthritis. So again, it's sometimes difficult to compare these diseases in one study. There's also not that much information on the impact of the additional diseases on physical activity from previous study. So I think that's why one of the things why we applied for the UK Biobank is to get that information in a good sort of structured way where everybody was asked the same questions about physical activity, about other diseases, about arthritis as well. So one of the first questions we want to investigate is people with arthritis, how often do they have cardiovascular disease or lung disease? Is there a difference between different sorts of rheumatic diseases? But also how different is that with the general population of those who don't have any arthritis? And then in addition we want to look at what is then the impact on physical activity in daily life. So to answer this question, we look at those who said has arthritis and those who didn't have arthritis. So the first thing is then to compare the number of people with cardiovascular disease in both populations. And you almost expect that that would probably be higher in the arthritis population, but we don't know yet. Then of course, the next step will then be to look at those who have arthritis and, for example, cardiovascular disease. What sort of impact may that have on physical activity? And is the impact lower or the same as those people who don't have any arthritis but still have cardiovascular disease? So at that way we try to understand how the impact is of all these diseases on daily functioning, because that's quite important for people. You want to go out there, you want to be able to make your meal, see your friends as well, go for a walk outside. So for that we will specifically look at activities in the home, activities outside the home, and also some of the demands of those who are still working. So the only thing we have done so far is briefly look how many people reported to have arthritis or one of the other rheumatological conditions in the UK Biobank. And as you see here, so there's about 1.2% said they had rheumatoid arthritis. And as you remember from the first slide, we did say that we expect about 1% of the people to have rheumatoid arthritis. We still need to confirm some of these findings because we're also going to look at the medication some of the people used. Osteoarthritis, so again that is a damage of the joints. That's more common, and that's also what we know is more common than some of the other types. Psoriatic arthritis, we see here that the percentage of 0.2 is slightly lower than what we expect from the general population, and there's other types of rheumatological conditions like gout or lupus, what we are going to look at. We just also briefly had a look at physical activities. So you may remember this question where you were asked about general activities, so walking for pleasure. So most people did that, about 30% of you did that on a regular basis. Other exercises, about 21% of you said, okay, we do some regular exercises like swimming or cycling. There were only a few percent, about 4.5%, who did really strenuous sort of sports, and I think that's a representation of any sort of within the whole population. And about 22% said they did some light DIY on a regular basis as well. So this information is something we're going to link with the other information. So that's one of the questions we want to address. The next question is another important question, and that's looking at sort of what are the factors that may, while you get develop rheumatoid arthritis or psoriatic arthritis, and other factors not. We already know from some of the studies and also from the Wellcome Trust studies, which was mentioned in the first presentation, that there are some genes that predict whether you will get rheumatoid arthritis, yes or no. But that's not the whole story. We know there are other risk factors. Smoking is probably also one of the bigger risk factors, but some studies also found something, a link with obesity. Some kinds of diets have been found to be linked with the development of rheumatoid arthritis, but also things like blood transfusion as well. But all these are very small parts, and they're definitely not the whole picture. So even that there may be somebody who has all the sort of the bad sort of lifestyle habits and have some of the genetics factors, and they still will not develop arthritis. So there's a big question mark still that we need to investigate. So again, what has been done in previous studies, a lot of people just look at genes, or they just look at some of these other lifestyle factors. They don't really often combine all these factors in one study. The other thing is that some studies find, for example, an association between obesity and the development of rheumatoid arthritis, but other studies don't. So it's really important to sort of repeat these analyses in a good sort of data set, where we either can confirm some of these analyses or even identify new factors which are quite important but we don't know yet. So the questions what we're going to address in the next 1.5 to 2 years are, especially when the genetic data is available as well, so which of these lifestyle factors, and there may be some factors we never thought about before, and they may come up as one of the risk factors, are associated with the development of rheumatoid arthritis. And we do sort of the same question in patients to look at psoriatic arthritis. So for that we need to do a slightly different, so we can't just start with everybody included and seen for the first time. So what we need to do is look at those patients who develop arthritis after they were seen. So we take all those patients who didn't say they had arthritis at the beginning, and then of course a number of patients were assessed at repeat follow-up. So then we look at that sort of second follow-up visit and look at those who developed arthritis, but again a lot of people will not have developed arthritis. And the next step will be to then compare at all these factors. So we look at the genes, we look at some of these factors which we already know are probably associated, but there may also be some other factors of all those questionnaires you had to complete that may come up, and that gives us some good clue what's going on and why people develop arthritis. So for us the main thing is the uniqueness of the UK Biobank is it can address some of the questions, hopefully to identify new factors or confirm some of these factors. With that we can advise people of the general population maybe to reduce smoking or do more exercise depending on what factors we identify. Also, if there are some certain genes and a person has some of these lifestyle factors, there are some ideas to say, okay, the chance that you will develop rheumatoid arthritis, for example, is so high, so we're going to give you short-term treatment with some of the arthritis medication. But you need to be very careful because some of these medications are very costly, and they also have some consequences because people may have some adverse events because of these medications. So that's sort of looking, ideally you want to sort of change the way some people, some of the lifestyle factors, but it could be that you give some advice in the short-term treatment as well. So that's the first part. And then of course the information about the outcomes is very important because we don't really know how all these sort of factors are linked, rheumatoid arthritis, some of the other diseases, and how big actually the impact is on daily living as well. So within the next 2 years we hope to address both of these. Of course this is not something I do by myself within the center, so Mike Cook, who's here as well, he started to do the analysis, and Jamie Sargent, the statistician, and John Bose, who has a genetic background, is part of this research team.